Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred for a dislocated IOL. It turns out this patient also is post-vitrectomy due to a retinal detachment repair. And this patient is a high myope, long axial length, and as you will realize in this case, also has a very thin sclera. And so post-vitrectomized, thin sclera, there's going to be scleral collapse. This patient also has a Soemmering's ring that I'm going to have to figure out how to take out. And so all of these are challenges because I have to take this lens out. The eye is unstable. The sclera rigidity is down. There's going to be scleral collapse. And it's going to be really a challenge to tunnel the scleral needles for the Yamane technique. So you're going to see all of these challenges in this case. So you can see this is a 3-piece lens. It is dislocated, obviously, here. And I'm going to start with marking first. So I'm going to dry the surface of the eye with a Wexel sponge. And then this is a 27 gauge cannula that's been inked at the tip. And I'm going to ink the limbus on the right side first. And then using the Wexel sponge to dry on the left side. And then using the cannula to find 180 degrees apart, being able to align properly. And then marking 180 degrees away on the left side. That's the fixed caliper. I'm indenting 2.5 millimeters posterior to that mark in radial fashion and then 2 millimeters adjacent. Indenting the sclera and then marking with the cannula with the ink. Doing the same thing on the other side, again indenting 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent and then marking the indentations. And that's the trocar. I'm indenting about 4 millimeters posterior to the limbus, tunneling about 3 millimeters through the conge and the sclera, and then diving down. You can see that the trocar cannula is sitting sideways, which means this will be a nice self-sealing sclerotomy. Making my incisions on the right side and then the left side, which will help me to take out this dislocated lens. And then making my contralateral limbal incision, which will allow me to externalize a leading haptic with the 25 gauge needle passive docking technique. This is the incision for my AC maintainer. And this is dispersive viscoelastic to coat the cornea. But again, I said this patient's been vitrectomized, so it is really not staying well in the anterior chamber and the lens is bowing back. And this is the 3 millimeter blade, again, at right angles to my mark. You can see the eye is indenting quite a bit, again, because it's post-vitrectomized and very thin sclera. Going in through the trocar cannula and placing the vitrector to support the lens. And then using microforceps to grab the optic in the left hand. And then using a second instrument to try to sweep each of the haptics into the anterior chamber. You can see there's also a Soemmering's ring, which I'm going to also try to keep from falling in the back of the eye. With the forceps being held in the left hand, I go ahead and cut the lens completely in half with the micro scissors. And then I'm using 2 forceps, one in the left hand and in the right hand, and I'm turning the lens piece so that I can grab it in such a way that the haptic won't scrape the cornea. But because, again, the patient's been vitrectomized, you can see how much the eye is collapsing as I pull that first piece out. And once that first piece is out, I want to quickly grab the second piece. Again, because there's no vitreous, the lens piece can try to fall back. And I'm going to turn this other piece, the right side piece, I'm turning it 180 degrees around because I don't want to pull with the haptic. If I pull by the haptic can pop off. So I'm grabbing the optic on the other side of the haptic, grabbing the edge, the cut edge, and then pulling it out of the incision using the other forceps to kind of provide some counterforce. And it comes right out. Again, you can see how much of the eye collapsing with that maneuver. I tried to use forceps to grab the Soemmering's ring in the bag. That didn't work. So now I decide to place the 22 gauge thin-walled AC maintainer tape it down with steri strips, and then I'm using a burping technique, just burping with the vitrector through the main incision, and very fortunate for me, the Soemmering's ring just burps right out of the wound. I do some more vitrectomy. Again, even though this patient's had a vitrectomy, it doesn't hurt to do some more vitrectomy just to be on the safe side. This is intracameral triamcinolone, just again to be double checking, making sure there's no vitreous in the anterior chamber, and there is no vitreous that I can see thus far. This is a 25 gauge needle. There's some BSS on a syringe here. I'm bending it with the bevel facing to the right. This is the right side needle, bending it about 9 millimeters from the tip. Again, the bevel is going to be facing the main incision, and then the left side needle, the bevel will be facing away from me. Again, all of the needles are mounted with syringe of BSS. This is a cartridge for the sensor lens. I'm pushing cohesive viscoelastic into the barrel and on the platform. And then very carefully placing the sensor lens within the platform, making sure the optic is tucked down. And as I fold the wings, the optic is tucked down. The leading haptics go straight out through the barrel. The trailing haptic goes out through the back, and the optic bends backward in a concave manner. I place the cartridge through the injector, and you want to make sure the trailing haptic is outside of the barrel, as you see here. It's sticking out. Push the plunger and advance the lens. Now this is a 25 gauge needle placed through the contralateral limbal incision. The bevel is facing the right. The bevel of the injector is facing the left. Both of the bevels will be facing each other. Therefore, the haptic is more easily able to dock on the bevel of the needle. My assistant is advancing the lens, and as she advances the lens, the haptic goes into the needle, and I'm able to pull the needle out, and the haptic comes straight out. Deliver the optic and then trailing haptic, pushing more dispersive viscoelastic to push the optic back. Using some forceps to pull the leading haptic out more, which pulls the optic away from me. Holding the trocar with the forceps as a counterforce. You saw I hesitated here and I got some bleeding, and that is because the sclera is so thin. I'm feeling like I'm puncturing too soon, but that's actually not true. I'm not puncturing too soon. It's just because this is such a thin sclera. So I stab at the first mark and I tunnel, and because the sclera is so thin, it feels like I'm too deep, but I'm not. I tunnel 2 millimeters and I dive down. I'm sliding the trailing haptic with microforceps, again, non-tooth forceps, non-serrated forceps. I slide it over, therefore it's atraumatic. I dock the haptic on the bevel of the needle and it goes right in. And so again, very quick maneuver, again, because I had good alignment and because I've externalized the leading haptic and the optics pushed away, so much better access to the trailing haptic. Disengaging the needle from the syringe, internalizing the leading haptic with the microforceps, holding the eye in contra-incisionally. By doing this way, I have better control of the eye so it won't move and it'll stay in the neutral position. The fluid is turned on, the eye is nice and firm. I'm stabbing the conjunctiva and sclera at the first mark. I'm tunneling. You can see the needle. Because the sclera is so thin, you can actually see the needle through the sclera, goes 2 millimeters, and I dive right down. Now I have turned the needle in such a way that I can align the needle to the haptic, and you can see the needle nice and rotated, and I have it in the place that I know where the haptic is going to be easily placed, so I can cannulate that haptic into the needle, docking the haptic on the bevel needle, rotating my hand, rotating my wrist, pronating it just a little bit, being able to align the bevel of the needle. I'm able to flatten the haptic on the bevel, and it goes right in. Pulling both needles out just a little bit, stopping on the right side, and then continuing on the left side, using microforceps to grasp the haptic as it comes out, and I'm trying to limit how much the haptic comes out. And that's another important point. A lot of people don't pay attention to that. They just yank and let a lot of haptic come out. Well, if you let a lot of haptic come out, you're going to cause more stress on the optic-haptic junction. You want to limit how much haptic comes out. Create a nice small flange. You see how flat the haptic is laying down on the sclera, which means that's excellent scleral support. Pulling the right side needle away from me, having my microforceps ready to grasp the haptic as it comes out, again, limiting how much of the haptic comes out as well. Again, limiting how much haptic comes out of the eye will mean you're going to have less stress on the optic-haptic junction. Drying the surface with the wet cell sponge around the haptic and then cauterizing the tip. Again, there's a lot of hemorrhage on the right side, but you can perceive and tell that the haptics are sitting nice and flat to the sclera, and that is because I've executed a nice scleral tunnel going 2 millimeters through the sclera. Again, feels different in this very high myope, thin scleral eye, post-vitrectomized eye. So that's why it's really based upon experience and just practice and understanding every eye is different. And knowing the dimensions of this eye, I had a pretty good understanding of what to expect with the scleral fixation part of the case. Reapproximate the conjunctiva, and this is the vitrector-assisted PI. I turn the port down, get a nice, discrete, and small peripheral PI. You don't want to go all the way into the angle, otherwise you'll eat the ciliary body. Do some more vitrectomy through the pars plana port. You can see the cornea is nice and clear, the chamber is deep. Doing now some more vitrectomy through the limbal incision. I knew there's no vitreous in this case because this patient's been vitrectomized, but I'm also trying to remove some viscoelastic. Now I'm using the cannula just to pulse into the angles to remove the viscoelastic from the anterior chamber. And here, this is a tendonylon suture. I always like to close my incision in these cases. I never want to see vitreous at my incision at the end of the case. Take the trocar cannula out, massage the eye, and then turn infusion on, and lo and behold, there is no ballooning of the conj, therefore that's a self-sealing sclerotomy. Take the AC maintainer out, and I'll hydrate my incisions and then inject some subconjunctival Ancef and Kenalox. So again, this is a patient with a dislocated lens, 3-piece lens, Soemmering's ring, post-vitrectomized because the patient had an RD in the past. This patient has a high myope, thin sclera, a setup for a challenging Yamane case. Pulling out the lens pieces in each piece, you saw how much scleral collapse that I had. And then when I tried to execute the Yamane technique by passing the needles through the sclera, you saw there was so much scleral collapse. And so that's the other important thing. You want to stay nice and flat, stab the conj and sclera, inflate the eye to get good control, and then staying nice and flat, I was able to tunnel 2 millimeters and dive down. If you stay too high, you will prematurely enter in these thin scleras, so you can't do that. And if you enter prematurely, you're at risk for having a flagpole sign, which means you'll have a tilted optic and essentially poorly executed technique. Luckily, after I got the lens pieces out, I was able to use a 22 gauge thin-walled AC maintainer to increase the infusion pressure and then burp out the Soemmering's ring. Again, because this patient's had vitrectomy, there was very little risk of any retinal issues with this maneuver. And again, when you pull out each of the needles after scleral fixation, you want to make sure you limit how much haptic comes out of the eye. Again, if you let a lot of haptic to come out, that means you are creating a lot of stress on the optic-haptic junction on the other side. I always limit how much haptic comes out when I pull the scleral needles out, and this helps minimize any stress on the optic-haptic junction, which is particularly important when you're dealing with the Sensar lens, which has a delicate PMMA haptics. Again, this patient had a dislocated lens, post-vitrectomized, history of RD, pretty challenging case, but as you can see, a perfectly centered lens in this patient who had a dislocated IOL in a challenging situation. So I hope this was helpful to you, and I thank you for your attention.